Welcome and thank you for joining the Lake Superior Quality Innovations Network Stroke Prevention and Atrial Fibrillation. Gloria Pizzo from IMPRO will now begin.
Good afternoon. My name is Gloria Pizzo. I'm a Quality Improvement Coordinator for the state of Michigan, which is a partner of the Lake Superior Quality Innovative Network. And welcome to today's session on this most relevant topic on stroke prevention and atrial fibrillation presented by Dr. Scott Kaatz. I will not delay in turning this over to him, but our Lake Superior partner, Metastar, is jointly offering continuing education credits for this presentation, and we need to inform you that there's no commercial support being received for this activity today. Dr. Scott will announce his disclosures prior to his presentation, and there are no plan or conflicts of interest. And for your CME credit or certificate of attendance, you must complete a short evaluation via the SurveyMonkey link that you'll receive during the webinar. We encourage everybody to please complete the evaluation to provide feedback on our learning session. It's now my privilege and opportunity to introduce Dr. Scott Kaatz. Warm welcome to Dr. Scott, and please take over the audience.
Great. Thanks so much, Gloria. Well, good morning or early afternoon. I'm coming to you from our Hurley Medical Center in Flint, Michigan. I serve as the Chief Quality Officer, so you may want to wonder why is a Chief Quality Officer talking about stroke prevention and atrial fibrillation. I spent most of my career at Henry Ford Hospital, and there I started the anticoagulation clinics and was the medical co-director of those up until I left a couple of years ago. And I've had an opportunity to participate in a lot of the trials involving the new oral anticoagulants. There is no sort of defined definition on what we're going to call the newer agents because some of them aren't so new anymore. So the best that I can come up with is the non-vitamin K direct-acting, target-specific oral anticoagulants that aren't so new anymore. That's a mouthful, so I'm going to call these NOACs or DOACs for direct oral anticoagulants throughout this talk. So also I practice as a hospitalist in around 4 months a year with the medical residents and students also here at Hurley in Flint. For full disclosure, here's my potential conflicts of interest. Of note, I've done, as you can see, with grant support. I've been involved in many research projects, mostly in and around the use of anticoagulants. I do some speaking, consulting, and I sit on 4 nonprofit boards. So our educational needs and learning objectives here is that we know that anticoagulants are underutilized in stroke prevention and atrial fibrillation. I will tell you this is one of my pet peeves, so thank you again, Gloria, for the opportunity to make my case on using anticoagulants appropriately for stroke prevention. I think in the United States we do a terrible job, and I'll show some data on anticoagulating, particularly our elderly patients, who are some of the patients that have the most to gain from stroke prevention. Our objectives will be to understand the magnitude of the anticoagulation underutilization and atrial fibrillation, be able to guide elderly patients through the risk and benefits of anticoagulation, and know the pros and cons of some of the new oral anticoagulants. And then my expected outcome, if I could get any of the prescribers on the call today to do something, not even by the end of the year, by springtime, if you could go back to your practices and convert many of your atrial fibrillation patients that are probably inappropriately on aspirin and move them over to an anticoagulant. And we now have, as of 2 weeks ago, 5 options to do that. Then I will have accomplished my personal educational objectives for this talk. Okay. Here's the outline. We'll go through each of these one by one. I will, please feel free to type in chat questions during, and I can see those, and if it comes up relevant to slides that we're talking about, I'll interrupt and answer those questions at that time, and then I'm going to try to give us some time for open up the mics and take verbal questions at the end of the talk. Let's talk about prevalence and incidence. So we're going to use the voting function here, and I hope that that will come up here in a minute on your screens and try to make this a bit interactive. Here is the question: an 82-year-old man in your office for annual physical Medicare physical, what's the chance that this patient has atrial fibrillation? So this is going towards a question regarding prevalence of atrial fibrillation. And Emily, are we able to bring that polling up? There we go. So we'll go 15 seconds, and please start the polling, Emily, and we'll take another 3-4 seconds to answer this. And I'll sprinkle a bunch of questions in throughout the talk. Okay, and could I see the results, Emily?
Yes, it'll be just a few more seconds.
Okay, thank you. This is where we need Jeopardy music. Okay. So lots of folks, so the majority, as we can see here, thought that this was 25%. So thankfully, it's not quite that high, but it is high. The correct answer is 10%. Here is a nice study from Alan Goh out of the San Francisco area now many years ago, actually, showing that 80-year-old men in the dark bars have about a 10% prevalence rate of atrial fibrillation, women having about a 7% as we move above 85 in the elderly. I think it's very important. In the 80-year-olds, about 1 in 10 of every one of those patients that you see will have atrial fibrillation, whether that's been diagnosed or not, because it could be paroxysmal and never picked up. But this sort of explains why our stroke rates are so high in the elderly patients also, but this is very, very common in the older patient. And so this therapy is very germane. Here is a really nice paper, just came out last summer, and what it is showing is it's showing the increase along the age, along the years at the bottom, and the ages, but look at what happens in this top graph, the prevalence of atrial fibrillation, getting up now in 2010, which is about 13 years past when the previous slide that I just showed you and paper that I showed you, some estimates up to 14%. I don't think that atrial fibrillation pathophysiologically is maybe changing that much. I just think that we have better diagnostic tools, and we're finding a lot of atrial fibrillation that we previously didn't find. One of those is in patients that have implanted defibrillators or pacemakers. We now, within the last 5-8 years, are pretty good about finding atrial fibrillation when we interrogate those pacemakers, and tell you from a personal standpoint, it's how we found atrial fibrillation in my father-in-law when he was 78 years old, and then we had him on, we put him on anticoagulation based on that. So we have tools that are finding this. So this prevalence of atrial fibrillation is increasing, partly because of our ability to diagnose it. So let's switch gears. So this is probably going to hit home for a lot of folks on the call. It certainly does, because I am is 46-year-old male patient in for annual physical exam. What's the lifetime risk of that patient developing atrial fibrillation? I apologize for the science or for the silence. but it'll take a couple more minutes to bring this up. But now this is going more towards the incidence of the disease. What are the chances that your patient, or for that matter, you will develop atrial fibrillation? And I think we'll have a couple more seconds of delay. Okay, good. So 25%, so almost half of the audience got this answer correct, and it is 25%. This data comes out of this paper in Circulation from about 10 years ago. And so everybody on the call that's 40 years age or older, this just got a very important talk to you, because you have about a 1 in 5 to 1 in 4 chance that you are going to develop this disease during your lifetime. And I fall into this age band also. Okay, let's talk about underutilization. Again, going back to some of Alan Bowe's work, one of the preeminent epidemiologists in the United States on atrial fibrillation and worldwide, showing the prevalence of use among over 11,000 ambulatory patients with non-valvular atrial fibrillation without a documented contraindication. And we see this very, very commonly, our hesitancy to treat patients. This, back at the time of this study, the only option was warfarin, so only a third of the patients that should have been anticoagulated were in this study. Some newer data, again from the paper I just showed from last summer. I think this is a wonderful commentary on public health, on what's happened since we sort of ushered in the use of anticoagulants in the early 90s. Our first study on primary prevention with a vitamin K antagonist was published in 1999 in the Lancet, and in 1989 in the Lancet, so a couple of years before this study. As we see the use of this is all warfarin data, increase over the last decade or two, we see a dramatic decrease in the rates of stroke, and we see this in both men and women. So really showing that as we've anticoagulated, we've really been able to reduce the rates of stroke. So very dramatic public health implications with this. What we do see, however, in this slide is if we look at the elderly patients, again, 85 years or older, we see the rates are only about 50% use of warfarin, where we're about 65% in this age band and this age band. So it's important for us to, I'm going to really concentrate on this group where we tend to shy away with anticoagulants, I think, inappropriately. The other issue is, as you can notice, sort of a dip down here over the last couple of years. The reason for that is because this is warfarin data, and this ushers in when the newer anticoagulants were introduced into the marketplace and became available for use. Okay, prediction tools. So the question is, how high a risk is it? Which patients actually are candidates for new anticoagulants? And I know although we talk about CHADS a lot, I still find some of my medical students will struggle with this to be able to individualize the risk of stroke. So here is a case, and I think we can start the timer and bring up the new question now, if you would. But a 74-year-old female with AFib, peripheral vascular disease, no other medical conditions. What's her CHADS score? And of course, that stands for congestive heart failure, hypertension, age, diabetes, and prior stroke. Please start the question. And just for some instructions, as soon as I bring up these slides with questions, Emily, if you'd be so kind to begin the polling also, that'd be great. All right, so I'm curious how many folks know to do this on the fly. I do this work all the time, so it's easy for me. It's not easy for some folks that don't do it all the time. And we're waiting. Great. Okay, so we have a smattering, but a lot of folks, the plurality thought that it was either a CHADS 1 or a CHADS 2. And I have to tell you, I tricked you on purpose because this patient has a CHADS score of 0. And let me show you why some of the risk stratification schemes. This is the original risk stratification scheme, the CHADS score, published by Brian Gage out of St. Louis, back now over a dozen years ago, showed nicely that as the score increased, so did the annualized risk of stroke increase. Okay? However, we know that there are other things besides CHF, hypertension, age, diabetes, and previous stroke or TIA that are predictive of stroke in the atrial fibrillation population. And those additional issues are if patients have vascular disease, i.e. prior myocardial infarction, peripheral vascular disease, or aortic plaque. We know that age is a strata. The older the patients get, the more likely they are to get a stroke. And then I've never heard a good pathophysiologic explanation yet, but we know that females have more strokes with atrial fibrillation than males do. So the CHADS VAS score was derived. Here's the point scoring on it to try to tease this out a little more. And in the original paper, we see that as the CHADS VAS score increases, so does the rate of stroke. Okay? So pretty straightforward there. But this paper is one of my favorite papers to explain why I think we should use the CHADS VAS score, looking at a Danish population back a couple of years ago. All of these patients are CHADS 0. But if a patient is CHADS 0, they could be 74 years old. That would get a point. They could be 74 and female. That would get them another point. Or they could actually have peripheral vascular disease. They could be more than 75, which would give them 2 points. So here is the different scores for CHADS VAS that you can get in these CHADS 0 patients. And as you can see, the rate of stroke increases as the CHADS VAS score increases, even though all of these patients would be scored as CHADS 0. So a lot of us for the last couple of years have moved and we would use CHADS 2 score, and if it was 0 or 1, then I would use the CHADS VAS score, but as you're going to see, the guidelines have now all aligned and suggested that we use the CHADS VAS score, and I'll show you some pragmatic tools on how to do that in a moment. Next question, let's fire up the polling now. Thank you, and we can start the timer. 78-year-old with atrial fibrillation and hypertension and a CHADS 2 score of 2, which equals a 4% annualized stroke risk. What's the chance that this patient will have major bleeding? Because we're always trying to do that balance. And to set this up while we're waiting for the polling to come up, is that we know that these risk factors, particularly getting older, is also a risk for bleeding. And so some folks have used the CHADS score as a surrogate for also bleeding risk. And one of the reasons I started the anticoagulation clinics at Henry Ford was because I noticed that the more I wanted to, or a patient needed to be anticoagulated, the more we didn't want to anticoagulate them. The 87-year-old dragging their hemiparetic leg behind their walker with diabetic retinopathy, you look at that patient and you go, oh my goodness, there's such a huge fall risk, I don't want to anticoagulate this patient. Yet, what we found is that those patients would be the ones that would benefit most. Well, it looks like we don't have the polling answers on this question, but let me advance the slide here. So this is a study that shows the CHADS score and the percent per year of major bleeding in the boxes in intracranial hemorrhage below, and you can see major bleeding went up as the CHADS score goes up. So what a lot of folks have noticed clinically holds true in the data. And here is what was developed by Greg Lippin out of the UK in his group was the Hasbled score. Here are the things to remember in the Hasbled score, and this works well to predict major bleeding in these patients. As the score goes up, the rates of bleeding goes up. So the issue is, which should we use? Because there are multiple bleeding risk scores. There's the Hasbled, there's an Atria out of a group that Alan Goh works with, hemorrhages out of Brian Gage's group who developed the CHAD score, and then we have the CHADS and the CHADS-VAS. So a group of us led by Jeff Barnes in Ann Arbor published last summer. We compared in a large group of patients in anticoagulation clinics with atrial fibrillation on warfarin what was most predictive of bleeding, and we found that the Hasbled was the best at predicting this, and all of the bleeding risk scores were superior to the stroke risk scores. So I do not recommend doing the shortcut of using CHAD score to predict bleeding. I think that we should formalize that. I will put this up just for a moment because as soon as I do this, everyone's going to go to the App Store and try to bring this up. This will be archived. I'll try to bring this up at the end of the talk, but I would look for this app. I have an iPhone, so it fits on my iPhone, and this will give you all of those risk calculators in one handy tool on your phone, and this is sponsored by the American College of Cardiology, and it has robust science behind the application. Okay. Quick question, and let's bring up the polling, please. In extracranial, so not intracranial bleeding, extracranial, whether this is GI, GU, etc., is 1, as bad as an ischemic stroke, 2, worse than ischemic stroke, or 3, not as bad as an ischemic stroke. Because when we have to figure out how we're going to balance our stroke risk with our bleeding risk. And let's see if we can get some results, please. And I'll give this another 5 seconds and see if the results will work this time. Well, I want to make sure that we have time for questions, so we'll, there we are. Okay. So, not as bad as an ischemic stroke, worse, and as bad. And it's actually not as bad. So the plurality of folks, again, most folks got this correct that voted. And let me show you this wonderful paper by Stuart Connolly at McMaster University in Hamilton, Ontario. Looked at a couple of large atrial fibrillation trials that he helped run. And the reference here is going to be ischemic stroke. And so this paper tells us that a patient that has a hemorrhagic stroke, bleeding into the brain, not necessarily bleeding into the head like a subdural would be, but bleeding into the brain, 3 times as likely to die compared to a patient with an atrial fibrillation-related ischemic stroke. However, a subdural bleeding into the head, still very worrisome, but not inside the brain, was about half the risk of dying, and an extracranial bleeding, i.e. GI bleed, GU bleed, GI bleeding being the most common, was about 2/3 the risk of dying. And that's where I want to do that. We many times will fear fall down, get a subdural. Patient has a history of diverticular bleeding 5 years ago, so we shy away from the anticoagulant. But this trial, this study shows us that those bleeds aren't as fatal as the bleed of the stroke we're trying to prevent with an anticoagulant, i.e. an atrial fibrillation-related ischemic stroke. So you can't do one-to-one, say, I save strokes, but I cause bleeds. Those do not have equal weights on the risk-benefit scale. So let's very quickly go through guidelines, and because these are going to be archived, I just am going to show just some quick snippets of this. I think I'm going to skip the polling here for the next several ones. But here is a case of a patient with a 75-year-old female with atrial fibrillation and hypertension, no other comorbidities. A CHAD score now of 2, age greater than or equals 75 and hypertension, but a CHADS VAS score of 4, because you get 2 points, not just 1 point, for being 75 years, and female gender adds 1, and I've calculated the has bled for you, and I can tell you in this patient, I would be using an anticoagulant, either warfarin. These slides got loaded a couple of weeks ago, so you will see not on the next set of information. I have not listed edoxaban, but edoxaban was approved by the FDA 14 days ago, so that's why, because these slides were loaded prior to that. So I don't have edoxaban in here, but that would be an option now that we should consider. So the American College of Chest Physician Guidelines. This field is moving so fast that a guideline that is now going to be 3 weeks old in a couple of weeks is really antiquated, tells you how rapidly this field is moving. So the American College of Chest Physician Guidelines will say for patients with a CHAD score of 2 or greater, they should be on an oral anticoagulant versus no therapy. And if patients are unsuitable to take an oral anticoagulant, this was really at the time these guidelines were written was sort of code for a vitamin K antagonist, i.e. in the United States, warfarin. Consider combination therapy with aspirin and clopidogrel. I can tell you I virtually never give patients aspirin and clopidogrel because although it does better job at stroke prevention than aspirin alone, it is inferior to warfarin, and in the atrial fibrillation population, it has the same bleeding risk as warfarin. So I get less efficacy with warfarin with no change in therapy. A lot of folks think that this combination for stroke prevention is safer than warfarin, and it actually isn't. We have that randomized trial in the New England called the ACTIVE-W trial. For patients, the recommendations in favor of oral anticoagulation, dabigatran, the only of the newer agents that was available at the time that this guideline was written, rather than adjusted dose warfarin. So the American College of Chest Physicians gave a nod to dabigatran at that time. Apixaban, rivaroxaban were not available, and of course, since edoxaban was just approved 2 weeks ago, that was not available at the time of this guideline also. If we move to a couple of months later, the Canadian Journal of Cardiology, the Canadian guidelines, were giving, in preference to warfarin, dabigatran, rivaroxaban, and apixaban. So looking at the advantages of those medications, not just from an ease of therapy, but also from some of the outcomes that I'll show you in a systematic review in the forest plots in a few moments, the Canadian guidelines were recommending going to the newer agents as a starting point. Okay? If we look to the American Heart Association and American Stroke Association, they recommend these 4. I think now if these got updated, we would add edoxaban that's FDA approved to this list. And then they recommended that we should individualize the decision of what now is 5 different options for anticoagulants for stroke prevention and atrial fibrillation, risk factors, cost, tolerance, and other characteristics, including the time in the therapeutic range. Let me back up for a moment and talk about this guideline for a minute, because I disagree actually with this last point. The time in therapeutic range, although it was shown in one of the trials to dilute the effect of the relative efficacy of new oral anticoagulant compared to warfarin, it was not seen in several of the other trials. So this has not been a consistent finding that really good INR control then makes warfarin a better alternative to the new agents. Seen in one study, not seen in a couple of the other studies. So if we look carefully at the science, on the surface, I agree that makes sense, and I have had lots of patients that are on warfarin, particularly managed in the anticoagulation clinic at Henry Ford, and a lot of times we would look at those patients and go, it ain't broke, don't fix it. So I agree with that. But I think that what we want to do is pay attention to what is best therapy for our patients, and I'm going to show you some of that data soon. The European Heart Journal, now published in 2013, basically was, let me just skip this slide. You can use this for reference, but let me go to this slide. Recommending for patients with CHADS-VASc. Number one, the European Society of Cardiology in 2013 recommended that what we do is that we use the CHADS-VASc score and not the CHAD score. I showed you some of that data, how it can particularly sort out the lower stroke risk patients. And they would recommend with the CHADS-VASc score of 1 unless that 1 point is only female gender. So they are not recommending giving the 37-year-old female with atrial fibrillation an anticoagulant because that patient has very low risk. The solid lines would recommend a new oral anticoagulant, and the dotted lines would be the alternative vitamin K antagonist, i.e. warfarin. Then if we move to last spring, so now the American Heart Association, the American College of Cardiology, and the Heart Rhythm Society guidelines published April 10th of last year. Now the big changes. One, they now align with the European Society of Cardiology guidelines to use the CHADS-VASc score. So I have now moved completely to using the CHADS-VASc score for risk stratification in my patients, and they are giving a level 1 recommendation for both warfarin and apixaban. The level of evidence, LOE, level of evidence, A for warfarin, B for the newer agents, is because we have multiple trials with warfarin, 5 for primary prevention, where we typically have only one trial for dabigatran, rivaroxaban, apixaban, and adaptoban comparing to a vitamin K antagonist. So those are the level of evidence. So it's sort of nice now we had this disconnect for about a year between the European Society of Cardiology and the older American Heart Association ACC guidelines, that those now are aligned nicely. Really important here, and is that the American guidelines recommend treating atrial flutter just like atrial fibrillation. Realize that atrial flutter was not in the AFib studies, and so it is not FDA labeled for atrial flutter, but what we've learned over the years is almost all patients with atrial flutter at some point will evolve into atrial fibrillation. So I can tell you, outside of package labels, is that I treat atrial flutter and atrial fibrillation from a stroke prevention standpoint exactly the same, and here are the guidelines that inform my decision. Creatinine clearance less than 15, and almost all the time when we talk about this, we are talking about by the Kopf Galt. I will tell you, it's another calculator that I have on my phone. I use the National Kidney Foundation's app that calculates these very easily. But there is a fair amount of controversy on what to do with patients with end-stage kidney disease and whether we should anticoagulate them because their bleeding risk are so high. But the recent American cardiology guidelines are recommending anticoagulating those patients. Okay, and then the recommendation down here is to not use these medications on patients with hemodialysis. All of the drugs, all of the 4 newer agents have some amount of renal excretion. although the FDA package label will say apixaban can be used in dialysis patients. That's done on a very small pharmacokinetic study. When I say small, I mean really small, 6 or 8 patients. Okay, clinical trial results of NOAC. So I'm just going to show you the forest plot because I could have spent the next hour and a half going through the details of each of the primary trials, all of which are in the New England Journal. But I just want to show you the pictures here. So this is primary efficacy. So this is stroke and systemic embolism. You can see that all of the drugs either are significantly less compared to warfarin or trend that way, except for low-dose edoxaban, and low-dose edoxaban was not approved by the FDA, so we don't have to worry about this one. What is dramatic is they all have less hemorrhagic stroke. The worst stroke, remember, 3 times greater mortality than a patient with an AFib-related ischemic stroke. Okay, you can see that they all reduce this across the board, all 4 molecules with 6 different doses tested. Non-hemorrhagic stroke bounces back and forth. So the big outlier here is low-dose edoxaban, and that wasn't approved, so we don't have to worry about that. And then systemic embolization, which is only about 4 or 5% of the events. We're really more worried about stroke in this disease. If we look at then the safety aspect, major bleeding, all using the same definition, the International Society of Thrombosis and Hemostasis definition, we can see a consistent trend towards less bleeding. Some of these by themselves will meet statistical significance in the trials, but a consistent trend towards this. Major GI bleeding, I think it's important, is what we'll do with several of the agents. We will have an increased risk of gastrointestinal bleeding, but they all decrease the risk of intracranial hemorrhage. And what I've always said is that if I was going to have bleeding, where would I rather have it in my head or in my gut? I think that's a pretty easy decision to make. I'm going to try to finish up in the next couple of minutes so I save lots of time for questions. We'll skip the polling for time's sake. There's a 90-year-old female patient with atrial fibrillation and hypertension and no other conditions. Here's the CHADS. The CHADS vast, the has bled. I would anticoagulate this patient. I would be nervous at 90 years old to anticoagulate this patient, but I would anticoagulate this patient. I think if I bring no other point home is that we have to, as a group of providers, stop being scared of these elderly patients. Let me show you some data. So first of all, no question, a study by Elaine Heilich many years ago showing that rates of major hemorrhage on warfarin much higher in patients over the age of 80 than under the age of 80. No doubt. Okay. If we look at rates of intracranial hemorrhage by Margaret Fang out of San Francisco, showing on warfarin in the top dark bars, off warfarin in the gray bars. What they do is they go up dramatically as patients get older. But patients off of warfarin also have much more intracranial hemorrhage, regardless of if they're on an anticoagulant or not. Excuse me. This study garnered a lot of attention. This is in the RELY trial with the Bigatran. This is a subgroup analysis led by John Eichelboom. And what we showed in this study is that in the older patients, what we had then is there was a tendency to get more bleeding with the Bigatran compared to warfarin in the patients over the age of 85. However, there was also a tendency to have less bleeding in the younger atrial fibrillation patients. But overall, this post hoc subgroup analysis showed that the relative bleeding rates with the Bigatran compared to warfarin were higher in the elderly. We, however, have not seen that with rivaroxaban, and we have not seen that with apixaban, and although I do not have a slide, we do not see that also with edoxaban. So I think it's really important to although know that major bleeding increased with the bigatran in the elderly. It was not sort of a family of medication effect. And so since the bigatran came out first, a lot of folks learned that and don't remember about the three other molecules. So what do we do with a patient that's 90 years old but also has had a history of falling 3 times in the past year? So what do we do with these atrial fibrillation patients that tend to teeter? Okay. This is a mathematical modeling study. Brian Gage is very, very good at this. Again, he led the CHADS score risk assessment score. Looking at intracranial hemorrhages and high-risk bleeding, okay, traumatic and non-traumatic, you're at higher risk for having bad bleeding and intracranial hemorrhage if a patient is high risk for falls. However, when we take that information and then add in what the risk of having a stroke is in patients on warfarin, CHADS 2 through 6, i.e. once you get into a little bit higher risk of having a stroke, what you do from a mortality standpoint is that you're better off anticoagulating the patients because you will save really bad events, sort of even money here with the CHADS score of 0 or 1. And then the biggest issue in and around this is that this is widely quoted. I apologize, the reference did not come out on the transfer to these slides, but there was a modeling exercise by Mansong that showed that a patient probably would have to fall about 295 times a year before anticoagulation would no longer make sense in anyone with a moderate or high risk of stroke based on, at this time, it was the CHADS score that was used. So I'm not quite this simplistic, but I'll ask the patient, how many times have you fallen this week? And if anything, I haven't fallen for 3 or 4 months. Based on this study, I will anticoagulate most of those patients. I do not let a walker or hemiparesis or Parkinsonism necessarily dissuade me away from anticoagulating my elderly patients. Some practical management issues, renal clearance to pay attention to. Edoxaban is not on this. The edoxaban renal clearance is 50%. Okay, protein binding. Edoxaban is heavily protein bound. So dialysis in the emergent situation doesn't make sense except for dabigatran. Okay, I'm going to skip talking about the P-glycoprotein efflux transporter system here. Here's a paper that we put out just last summer. It's already out of date. So these were what was coming out of the package inserts probably in about May when we submitted this paper. It is already outdated. The point of showing this slide is that you have to look at the interaction of drugs that have liver metabolism, P-glycoprotein efflux transporter interactions, and renal function. And all 3 go into this. And the package inserts, boy, they evolve about every 3-4 months, adding different drugs to the list and or adding different estimated creatinine clearances to the list. Okay? What about periprocedural interruption? The broad concepts is what we want to do is pay attention to what the half-lives are, so this is based on kinetics. Very nice pragmatic paper on how to manage this by Alex Paropoulos and Jim Tutetis, sort of a couple of the leaders in bridging therapy with the literature worldwide, and I'd recommend this as a reference on how to manage patients very procedurally with the newer agents. Edoxaban information was not out at the time that this was published 2 years ago. Okay. Nice study by Dave Garcia at the University of Washington in Seattle, just talking about laboratory tests. In the very end, let me just tell you, the bottom line is lab tests aren't very good. Maybe with the Bigotrend having a normal PTT, you're relatively sure that there's not important anticoagulant effect on board. With rivaroxaban, if the prothrombin time, not the INR, the prothrombin time is completely normal, you're probably reasonably sure that there are not important drug levels affecting anticoagulation. What to do to reverse in the package insert? All of the package inserts will recommend in very emergent situations you can get prothrombin complex concentrate either in the inactivated or activated form or recombinant factor 7A. But when you look at the data behind that, this was from a updated table that Deb Siegel helped me with a publication a couple years ago. What you're going to see is that you're going to see human volunteers, animal modeling, etc. So the data is not robust. There are 3 specific antidotes in development now, but none of them are commercially available, and they really just have moved into definitive studies, so we're probably a year or so from seeing the results of the first one, and then maybe longer than that for approval process. So what I've tried to discuss is prevalence and incidence of atrial fibrillation, emphasize that we underutilize anticoagulation in atrial fibrillation. The data is really extrapolated from warfarin studies, talked about the atrial fibrillation risk prediction tools, went over briefly the guidelines, the clinical trial results. One of my pet peeves, as you could tell, is that I think that we are woefully mistaken in not anticoagulating many of our elderly patients, and then just a couple of pragmatic issues on how to manage the new oral anticoagulants. And I will, here is a tool for your reference on what to use with triple therapy, dual antiplatelet plus an anticoagulant. I'm not going to go over this dense table, but I would recommend looking at the European Heart Journal for these guidelines. And I will stop there and happy to take questions. I'll turn it back over to you, Gloria.
Thank you, Dr. Chase. Ashlyn, could you please open up the phone or the line for questions?
Yes, ladies and gentlemen, if you have any questions at this time, please press the number 1 key. Again, if you have any questions at this time, please press the number 1 key.
And Ashlyn, could you open up my screen so that I could see any of the typed-in questions? And Gloria, while that's happening, do you have any questions that have been typed in?
We don't have any current questions.
Okay, great.
And at this moment, we have no current questions in queue.
Okay. So I'm happy to field questions. I find this is actually one of the more fun parts of talks. I think it brings folks together a little bit too, particularly when we're doing this virtually. For the some of you that aren't doing emails on your other screen right now. Gloria, while we're waiting for folks to send in questions, do you want to make any remarks about the innovation network?
Absolutely, thank you. For any of our participants that are interested in participating in any further quality improvement initiatives, please contact your local representative. For the state of Michigan, you can contact Christy Mims, and in our Lake Superior partners, you can reach Jerry Hineker at the set addresses and phone numbers in Minnesota and Marnie Anderson in Wisconsin. I wanted to thank you all for participants for attending and for participating in the polling questions. And I will follow through with your information on the CME credits and attendance for certificates. Attendees, please complete the evaluation via the survey link below within the next 2 weeks. That's the surveymonkey.com. Thank you so much for forwarding that. Dr. Scott, I would just like to thank you too as well for sharing your comprehensive knowledge and your expertise with our audience today, and confidence in saying that it was very beneficial and valuable to our audience. We look forward to future learning events hopefully with you.
Okay, thanks so much, Gloria. Thanks, everyone. Bye-bye.
Ashley, are there any questions on the line?
Actually, we did just receive a question from Jocelyn. Jocelyn, please go ahead.
Yeah, we were wondering if there was any credits for the nursing home administrators.
If you will send me your email address, Jocelyn, I'll follow through with that with Wisconsin.
Thank you.
And there are no more questions in queue at this time.
Okay, great. I'll sign off. Thanks so much.
Thank you, everyone, for participating.
This now concludes our call. You may all disconnect and hang up.
Thank you.